headache on and off for last 45 days. I'm having some issue with, okay. So she was apparently asymptomatic 45 days back when she noticed swelling in both her lower limbs. It was insidious in onset, progressively increased in size, associated with reduced urine output, not associated with pain, discharge, or any color changes, aggravated on prolonged standing or walking, and slightly reduced on lying down or elevating legs. She also had complaint of headache for 45 days back, which was on and off, insidious in onset, constricting in nature, moderate in severity, associated with dizziness and blurring of vision for the last 10 days. She had no aggravating factor or aggravating factor noticed. The pain subsided on its own or on medication. There was no history of nausea, vomiting, or similar headaches in the past. With the above mentioned complaint, she visited obstetric outdoor 1 month back, where it was found that her blood pressure was severely raised, which was 190 over 110 millimeter of mercury. She was prescribed tablet labetalol 200 mg 3 times a day and tablet nifedipine retard 10 milligram twice a day. Her symptoms of headache was reduced in frequency after the start of these medication. She is also a known case of hypothyroidism for last 10 years and is currently of 100 micrograms of thyroxine tablet per day. There was no history of black spots in visual fields, diminished visual fields, or complete blindness. There was no history of seizures, clouding of consciousness, altered mental status during the current pregnancy. There was no history of upper abdominal pain or right upper quadrant pain. There was no history of breathing difficulty, hoarseness of voice. There was no history of purpuric rash, hematuria, or heat and cold intolerance. So in the past history, patient didn't give any history of hypertension, diabetes mellitus, bronchial asthma, tuberculosis, seizure, or renal disorder. There was no history of any surgery or trauma in past. There was no history of any prolonged medication or hospital stay. There was no history of blood transfusion, chest pain, dyspnea on exertion, palpitation, or loss of consciousness in past. In obstetric history, she is a primary gravida with 36 weeks and 2 days of pregnancy, and she has been married for last 45 years. For 4 years, she was diagnosed at home by urine pregnancy kit, and she has had 3 antenatal visits in the current pregnancy, 1 in first trimester, 1 in second, and the third around 1 month back. She took folic acid, iron, and calcium supplements regularly. She took 2 doses of tetanus toxoid. There is no history of excessive vomiting, fever, rash, pervaginal bleeding, pervaginal discharge, or dyspnea in current pregnancy, and there was adequate fetal movement perception. In her menstrual history, she has attained menarche at the age of 15 years. Her cycles are regular, lasting for 3 to 4 days and of 30 to 33 days duration, and it is not associated with pain or clots. Her last menstrual period was on 25th July 2021. In personal history, she's a non-vegetarian. There is no habit of smoking, tobacco chewing, or alcohol consumption. In bladder, her frequency of urination is reduced, and there is also lower urine output as per the patient. A bowel habit, there is constipation often present on and off. Her sleep appetite are normal. There is no history of any known allergies. In family history, her father is a known hypertensive and was diagnosed at the age of 50 years. And no any other significant systemic illness is noticed in family. There is no history of eclampsia or preeclampsia in family also. Should I stop, Sarna?
Yes, Neha.
Yes, sir.
You mentioned there is no history of eclampsia and preeclampsia.
Yes, ma'am.
Why did you ask this specifically?
Ma'am, there has been studies that it is common eclampsia, preeclampsia and eclampsia are commonly run in the family. If there is any previous history in family, there is a chances that this patient was predisposed for having preeclampsia also.
So you have not, okay, now you will go to proceed to the examination because we would like to know the blood pressure and the other things in the patient.
Okay.
Anybody else wants to ask anything or add on something? If you just summarize your history till now, one is you said patient has swelling in the feet. Can you summarize the important, significant positive points?
Yes, ma'am. She
Okay.
had bilateral swelling in both legs.
Yes.
Then headache, complaint of headache, and she has been having blurring of vision for the last 10 days and complaint of dizziness also.
And decrease urine output also, you
Yes, ma'am.
mentioned.
Decrease urine output also.
Okay. So can you read the diagnosis just based on history? Any provisional diagnosis?
Yes, ma'am. We are suspecting it towards hypertensive disorder in pregnancy, but we can't tell it. We can say it's severe preeclampsia also because of the involvement of CNS system and also of renal system in this case.
Okay. And can you tell me why did you ask about the right upper quadrant pain or the right hypochondrium? Pain?
Yes, ma'am. There is also associated elevated liver enzymes are also seen in cases of preeclampsia with severe features. So that's why I asked about that. And there can be also some liver hematoma can be also there, which can cause pain in the right upper quadrant. And commonly patients have associated epigastric pain in severe preeclampsia also.
And also you wanted to rule out HELP syndrome.
Yes, ma'am. Yes, ma'am.
Okay. I think you can proceed to the examination.
So in examination, in general physical appearance, her height was 158 centimeter, weight was 73 kg. Her BMI was 29.24 kg per meter square. She was conscious, alert, cooperative, well oriented to time, place, and person, sitting comfortably on bed, and slight facial puffiness could be noticed on her face. In vitals parameter, her pulse was 97 beats per minute, regular in rhythm, normal in volume. Arterial wall doesn't appear to be thickened, no pulse deficit, no radial delay, no radiofemoral delay, and all peripheral arteries were palpable. Her blood pressure was 159 over 96 millimeter of mercury in left arm in sitting, was taken in left arm in sitting position. Her temperature was 98.8 degree Fahrenheit. Her saturation was 96% in room air. In general examination, bilateral pitting edema was present. Bilateral bipedal pitting edema was present. Also, there was lumbosacral edema was also present. In pallor, icterus, clubbing, cyanosis, cholionicia, and lymphadenopathy were all absent. In airway examination, her oral hygiene was good. There was no loose dentition present. Bucktooth was absent. The length of the upper incisor was 1.1 centimeter. Her interincisor distance was 5 centimeter. Mandibular protrusion was normal. Mallampati grade was grade 2. On palate examination, there was no narrowing or high arching noticed. Thyromental distance was 8 centimeters. Sternomental distance was 14 centimeter. Her neck circumference was 38 centimeter. And head and neck range of motion was normal. And there was no enlargement of thyroid noticed in neck.
Sneha, your slides are not visible. Are they visible to others? I cannot see the.
Sneha, you can just share the slide.
Please share the slide.
Okay.
Slide share तुम्हारा बंद है.
Oh, okay. So this was the general appeal. Should I say it again?
No. You proceed to that slide where you were discussing.
Okay.
Yes.
So
we examine the airway.
Yes, ma'am.
Yes.
In systemic examination, in respiratory system, her respiratory rate was 15 breaths per minute. There was no use of any accessory muscles of respiration. Trachea appears centrally placed. Bilateral chest was moving equally with respiration. There was no chest deformity seen. No audible wheeze or stridor was heard. No visible lump, ulceration, or scar mark was seen. No neck vein engorgement or pulsation was seen. Mild venous prominence was noticed over the bilateral breasts. In palpation, findings of inspection was confirmed. Chest expansion was bilaterally symmetrical. Trachea was centrally placed. No tracheal tug was noticed. Tactile vocal fremitus was bilaterally equal. No area of tenderness was noticed. Axillary and supraclavicular lymph nodes were not palpable. In percussion, resonant sound was heard in all areas of the lung field. Liver dullness was heard from the fifth intercostal space on the right side. On auscultation, bilateral vesicular breath sound was heard. Bilateral inspiratory fine crackles was heard. A wheeze was absent, bronchi was absent, and visceral pectoral equi was normal, and bilateral vocal resonance was equal. In cardiovascular system examination, on inspection, there was no visible precordial bulge, no visible pulsation. Apical impulse was not visible. There was no dilated vein, scar, lump, or sinus, and no chest deformity was observed. On palpation, findings of inspection was confirmed. Apex base was felt at left fourth intercostal space, just medial to mid-clavicular line, regular and gentle tapping in nature. No palpable trail, parasternal heave, or epigastric pulsation was felt. No venous hum or carotid trail was felt. On percussion, normal areas of cardiac dullness was found. On auscultation, first and second heart sound was heard. Second heart sound was louder in intensity. In pulmonic and aortic areas, normal splitting of second heart sound was heard on deep inspiration. There was no murmur, pericardial rub, no venous hum or carotid root heard. In abdominal examination on inspection, abdomen was piriform in shape and corresponds to the period of gestation. Linea nigra and stria gravidarum was present. Umbilicus was centrally placed and flat. Fetal movement was present. No scar, lump, or visible pulsation was seen. No dilated blood vessel was seen. On palpation, fundal height came out to be near xiphisternum, about 36 weeks in size. Mild tenderness was elicited over the fundal area. Uterus was soft and relaxed. Fetal presentation was cephalic, and back was felt on the right side. Head was floating. On auscultation, fetal heart sound was auscultated via the bell of the stethoscope on the right spino-umbilical line. Fetal heart rate was 148 beats per minute and regular. In CNS examination, higher mental function was normal. Cranial nerve examination was normal. There was no sensory or motor deficit noticed. Pupils were bilaterally mild dilated and reactive to light. Superficial and deep tendon reflexes were normal. Her neck rigidity was absent. Waddling pregnant gait was present. In a lumbar spine examination, there was lumbosacral pitting edema. Lumbar lordosis was present. Intervertebral space was palpable after manipulation, suggesting difficult spinal. So that is my examination findings. Ma'am.
Can we proceed for discussion?
Yes, ma'am.
Okay. So we have summarized it, the examination findings.
Yes, ma'am.
Yes.
So,
Okay. So what is your diagnosis now? Provisional diagnosis after your examination findings you have.
So my provisional diagnosis would be she is a primary gravida with early onset preeclampsia with severe features.
Okay. So when do you say, how do you define preeclampsia?
Preeclampsia is actually defined as onset of hypertension and proteinuria after 20 weeks of gestation. So hypertension has to be more than 140 by 90 millimeter of mercury, taken at least on 2 occasions, 4 hours apart. And proteinuria has to be either 1 plus or more than 300 milligram per day.
And what is severe preeclampsia?
In severe preeclampsia, ma'am, there is evidence of end organ dysfunction. It could include in CNS, and it includes either hyperreflexia, hyperexcitability, blurring of vision, then
First is blood pressure. What is the criteria for defining it as
Yes,
severe?
ma'am. For severe, it should be more than 160 by 110 millimeter of mercury for severe preeclampsia.
Okay. Anything else?
Yes, ma'am. Should be elevated liver enzymes, thrombocytopenia, then renal system involvement, decrease in urine output. Then there is in lungs there could be
Do you think proteinuria is still a criteria?
no, ma'am. Proteinuria has been removed
Yes.
from severe criteria.
Okay. Earlier it was said that when there is loss of 2 grams of protein in 24 hours, then you would say. But
Yes,
no, proteinuria is no longer the criteria. So one is the
Yes.
blood pressure. Then a rise in serum creatinine is also one of the important criteria. And
serum
decrease in platelet count,
Yes, ma'am.
decrease platelet count, or if there is persistent headache is also one of the persistent
Yes,
headache
ma'am.
along with visual disturbances
Yes, ma'am.
and persistent epigastric pain.
Yes, ma'am.
Because which is again an evidence of hepatocellular necrosis or
Necrosis.
ischemia or edema of the capsule of the liver.
Yes, ma'am.
Okay. So how do you differentiate it from eclampsia?
In eclampsia, along with the features of preeclampsia, there would be presence of seizures in the patient. Seizures could be generalized. Seizures are mainly generalized tonic-clonic type of seizures in the patients.
And does it occur only during pregnancy?
No, ma'am. It can occur up to 48 hours or up to maximum up to 7 days after delivery also.
Even weeks have been mentioned that there may be, yes. Usually we take like up to 7 to 10 days of postpartum. The seizure, the commonest cause of eclampsia, commonest cause of convulsions during pregnancy is eclampsia.
Yes, ma'am.
Okay. Dr. Badani, you want to add or shall we proceed?
What are any other causes of edema of feet? It's seeing the history and others. Naturally, the most common cause is here the preeclampsia. But what other thing can cause feet edema?
So there is also physiological edema is seen, but other causes could include hypothyroidism also in this patient. We could suspect, but that would be non-fitting edema, and could be congestive cardiac failure in this patient also for bipedal edema.
So how to rule out it is not due to congestive cardiac failure?
So first, there would be symptoms of orthopnea, dyspnea, and progressive fatigue in the patient. On examination, JVP would be raised in the patients of congestive cardiac failure also.
And what about hypothyroidism? She is taking 100 milligram of thyroid.
Yes, sir. Yes, sir. So in
So how much
hypothyroidism,
this is contributing in edema, or there is no contribution of this?
sir, I'm not sure, but there may be contribution through this also. So,
but in itself, what are the 3 cardinal features which is essential to diagnose preeclampsia?
Sir, elevated blood pressure, then proteinuria, then
edema.
edema. Yes.
That's what we are discussing.
Yes, sir.
Okay, so in your clinical picture, you have taken blood pressure.
Yes, sir.
And since how long the patient is visiting the doctor?
So for last 1 month, sir, she had been visiting.
And the hypertension was diagnosed since last 1 month.
Yes, sir.
And here the BP which you are showing is pretty high.
Yes, sir. 159/96.
Not very good control.
No, sir.
No.
Yes, sir.
Okay. So, other than the examination related to the pregnancy, any other positive finding other than your pregnancy related like edema and others? Any other positive finding which you should think due to its coexisting disease? She has got now you can summarize by history what she is suffering from.
Yes, sir.
You summarize in 1 or 2 sentences.
In examination findings also, you have mentioned something in the respiratory system.
Yes, ma'am. There was bilateral Krebs also present.
Yes. So what do you think is the cause of bilateral Krebs?
Ma'am, could be pulmonary edema that has been developing due to increased capillary permeability.
So what do you think? What are the complications of why we are worried about preeclampsia, severe preeclampsia? What all it can lead to if it is not diagnosed or treated timely? What
If it is not,
complications? Yes.
ma'am, it can lead to ischemic heart diseases in patients. Then congestive cardiac failure, left ventricular diastolic dysfunction, and as well as then progressive renal failure can occur in patients. And if blood pressure is also not controlled or severely uncontrolled blood pressure, it can cause intracranial hemorrhages also
Yes,
in
very
patients.
important. Intracranial hemorrhage. Then DIC.
Yes, ma'am. DIC HELP syndrome in patients.
Pulmonary edema, you yourself mentioned.
Yes, ma'am.
Then it can, what are there can be some obstetric complications because of this, like abruptio
Yes, ma'am.
placenta can occur,
Abruptio
postpartum
placenta.
hemorrhage can result.
IUGR can also occur, ma'am.
Yes. And as you said, this patient has this pain. This can also lead to liver rupture.
Yes,
Or
ma'am.
patient can land up with CVA or something. Then there
Yes.
can be some fetal complications. What are the fetal complications because of severe preeclampsia?
Ma'am, there can be growth retardation in the fetus.
Yes.
There can be abruptio placenta that can further cause fetal demise or fetal loss in the pregnancy. Then
Preterm labor can occur.
yes, ma'am, preterm
Then
labor.
also oligohydramnios is known to occur. Intracranial hemorrhage in the baby can occur in the fetus. Okay.
Okay.
And the child can be small for age, small for gestation age.
Yes,
And even it is known that the meconium aspiration is likely to be more in such patients,
okay.
such fetus. Okay. So can you just tell me what is the pathophysiology of this eclampsia? Why does it occur?
Ma'am, it is said to occur because of incomplete remodeling of the spiral arteries. Fetal decidual fetal cells fail to progress and invade the spiral arteries, especially in the decidual and myometral part. And normally, when fetal cells infiltrate the spiral artery in the myometral and decidual part, they cause its dilatation, and these spiral arteries become resistant to vasomotor stimuli. While in this pregnancy, the fetal syncytial trophoblasts couldn't progress up to the myometral level, and are only partial invasion in the decidual part of the spiral artery occur. That causes these spiral artery to remain constricted and hyperresponsive to the vasomotor stimuli.
Basically, there is abnormal presentation and also there is incomplete remodeling of the uteroplacental spiral arteries, which you mentioned. Okay, so this usually occurs in the second trimester.
Yes, ma'am.
And it can proceed on even in the third trimester. So basically, sometimes there can also be late uteroplacental dysfunction.
Yes, ma'am.
Okay, so this can lead to fetal problems as well as the maternal problems. Okay, so as you said, almost all the systems are involved. As in your patient, you said your patient had edema, pulmonary edema also you suspected. So what would be the management of this patient now? Because this patient is presented to you with the hypertension.
Yes.
Hypertension, what are the drugs which are commonly used for control of hypertension?
Ma'am, commonly drug used are labetalol, which is a combined alpha and beta blocker. Then hydralazine, methyl dopa.
How much is the beta activity of labetalol?
7 times is beta activity is 1 times, and alpha
1:7. Yes.
1:7. Yes, ma'am.
Okay. So then what else?
Then nitroprusside, nitroglycerin also used for injection. Then
this will be for acute control of hypertension.
Yes, ma'am, for acute.
When we talk about acute management, that will be different. Firstly, these patients are either on methyl dopa or labetalol. Yes, so labetalol is contraindicated in which group of patients?
Asthmatic patients and congestive cardiac failure patients.
Yes. Okay. So they can be started on oral medication. Then we talk about the acute management of hypertension. Like if this patient presents to you with hypertensive crisis, then certain drugs need to be used. So what all drugs can be used for control of acute hypertension?
For acute hypertension,
See, this is how this patient presents to you with acute hypertension. You first need to stabilize the patient before you plan the actual management.
we go for night. Ma'am, I think I'm getting some echo here.
Okay. Is your phone nearby? You can remove that.
Yes.
I'm 10 minutes more.
Yes.
Okay. So
Quickly.
for acute cases also, we can use labetalol infusion, nitroglycerin infusion.
Dose of
Then
labetalol for acute management.
what?
Labetalol, what dose you will use?
Ma'am, 10 to 20 milligram IV is to be used, and further dose increment can be done up to 200 mg.
You can give go up to 20 milligrams intravenously, and this can be done given 20 milligram can be given every 10 minutes, or you can start an infusion in a dose of 1 to 2 microgram per minute. Okay, but maximum dose allowable dose is 220 milligrams.
Yes,
Remember that. Okay. Then other than this, what other drugs can be used for control of acute hypertension? You yourself mentioned.
Hydralazine is also given intravenously, 5 mg. We start with 5 mg IV dose of hydralazine.
Every
Then
20 minutes, you can repeat it until a dose of 20 milligrams is given.
20. Yes.
Then other than this, anything else? Calcium channel blocker? Nifedipine can be used sublingual.
Nicardipine is also 5 mg.
Nifedipine injectable, yes. 5 milligram.
And it is incremented with 2.5 mg every 10 to 20 minutes, and can be increased up to maximum 15 milligram nicardipine.
Okay. So what else you need to optimize before this? If your patient is in pulmonary edema, what do you think is the cause of? First is why your patient is having headache. What is the cause of headache?
Ma'am, first could be cause of headache could be because of increase in blood pressure also, and second is second cause be because of.
What is the cause of rise in blood pressure and in this thing? It is basically the vasospasm of the vessels.
Yes, ma'am.
Vasospasm which is there, and also cerebral edema can be there sometimes.
Yes, ma'am. Cerebral.
Okay. So you can you need to know all the involvement of all the system and what is the cause of involvement. So like there can be fluid and electrolyte imbalance because there is decrease in plasma oncotic pressure.
Yes, ma'am.
Okay. Then what happens to the cardiovascular system? As you said, there is increase in the afterload, so patient can go into CHF.
Yes, ma'am.
Okay. Then other than this, kidney you need to remember the patient can have oliguria and and also proteinuria. Liver you also mentioned that there is increase in the enzymes and which leads to all those pains. And then what is HELLP syndrome?
Ma'am, HELLP syndrome, there is a hemolysis, elevated liver enzyme, and thrombocytopenia. For criteria, this for hemolysis, there should be on the peripheral blood smear, there should be schistocytes and Burr cells should be present on the peripheral blood smear. LDH levels should be more than 600 international unit per liter, mg per dl. Then platelet count should be less than 1 lakh. And AST level should be more than 70 international unit per liter, and serum bilirubin should be more than 1.2 gram per dl, milligram per dl for the diagnosis of a HELLP syndrome to be made.
So in CNS system, you need to know that there is involvement of patient can have cerebral edema, patient can have visual disturbances, patient can have focal thrombosis, or there can be hemorrhage in the retinal vessels also because of uncontrolled blood pressure. So that is one. So what is the actual management of, you know that the culprit is uteroplacental unit.
Yeah, yes, ma'am.
So the termination of pregnancy is this thing, especially, and what would be the immediate delivery will be required when? There could be
immediate delivery is required if patient is having eclampsia, having pulmonary edema, HELLP syndrome, and if cerebral edema features are also there, then we should go for immediate delivery of
and uncontrolled blood pressure, which may last for more than 24 to 48 hours. Okay.
Yes.
Also, progressive thrombocytopenia is an important factor. Progressive decrease in platelet count. The trends of the platelets is also very important. Also progressive renal dysfunction if patient has, or as you said, eclampsia if it occurs. Okay.
Yes.
These would be the indications of termination of pregnancy. So now your patient has been come to you and has the BP has been optimized. What will be your plan of anesthesia for this patient?
Ma'am, plan of anesthesia will depend on the condition of the patient. So if we are suspecting difficult airways and if patient is in HELP syndrome or having a lower platelet count or any hemodynamic instability, then we would decide accordingly. We would decide for either going for regional or neuraxial block or for going for GA. For a regional block, we would prefer in most of the cases I would prefer a neuraxial block, because in these patients airway edema is also present, so there can be a risk of difficult airway management in these.
So as you know that these patients have systemic vasoconstriction, what are your concerns when you are planning an neuraxial block? Because they also have contracted plasma volume.
Yes, ma'am. Though it has been seen that contracted plasma volume is by 40% reduction in plasma volume is also seen in this patient, but there is also increased circulating catecholamine level, and there is also increased sensitivity to catecholamines and vasopressors also. So even if we give neuraxial block or central neuraxial block, there's less evidence of hypertension seen, and even if hypertension is seen in these cases, they can be easily manageable by low dose of vasopressors also in these patients.
Which vasopressor is preferred in these group of patients?
Ma'am, phenylephrine is preferred in these patients in in lower dose of 25 to 50 microgram.
Okay. But this patient can also have, sometimes they can have diastolic dysfunction, or there can be decrease in ejection fraction and decrease in cardiac output. So if that involvement is of cardiovascular system is to such an extent, then also you would like to go for.
No, ma'am. Then I would prefer general anesthesia in these patients.
Okay. And what is the other, if you go for general anesthesia besides airway concern, what is the other concern? One is the hypertensive response to laryngoscopy and intubation can be there.
During intubation and extubation, there can be severely increase in hypertension, severely shoot up of blood pressure in these cases that can cause intracranial hemorrhage also in this patient. So we have to control those shoot up those blood pressure elevation at the time of intubation as well as extubation. Also, if these are eclampsia patients, those who have been given max-self prophylaxis, or severe preeclampsia patients, those who have been given max-self prophylaxis can have respiratory depression in those patients, or also there can be potentiation of neuromuscular blockage in these patients also.
How does magnesium sulfate act? How does it has a prophylactic as well as therapeutic role in patients with seizure? Why magnesium sulfate is preferred?
Ma'am, magnesium sulfate is preferred because first it decreases systemic vascular resistance by acting on the splanchnic nervous system. It has anti-inflammatory properties, reduces cerebral edema, reduces cerebral metabolic oxygen demand also, and via acting on the NMDA receptors, it increases the seizure threshold and controls the seizure.
It is also, it is an NMDA receptor.
Antagonist.
Yes. So it inhibits acetylcholine release also.
Yes, ma'am. For it inhibits acetylcholine release from the presynaptic terminal.
Potentially your neuromuscular blockade. You
Yes,
need to remember that. Also the calcium channel blockers, if they have been used, you need to be careful with that. Then also it decreases CNS catecholamine release. But remember, if the patient is on magnesium, there is a concern about something intraoperatively, PPH.
Yes,
because it is smooth muscle relaxation.
Relax.
Okay. And also it causes decrease in peripheral vascular resistance. So what are the adverse effect of magnesium? Just to enumerate this thing. One fetal as the mother.
Ma'am, commonly side effects seen with therapeutic doses of magnesium sulfate.
How do you give magnesium if patient is having seizure? What is the dose?
Ma'am, commonly two regimes are seen. I don't remember the name of the other regime. Here we use Pritchard regime, and where we give 14 milligram of loading dose. 4 milligram IV is given intravenously, diluted, and then
4 milligram per gram.
4 gram, I'm sorry. 4 gram is given IV diluted, and then 5 gram is given in each buttocks. And then further 5 milligram is alternated after every 4 hours. And in other regime, we give loading dose of 4 to 6 gram IV. Then 1 to 2 gram is continuous infusion is given.
Yes, you can use that.
Yes.
Okay. So we were talking about the adverse effect. One is potentiation of neuromuscular blockade. What is the other concern? It can also lead to respiratory depression in the mother. Can cause significant hypotension. As I said, atonic PPH is important because it decreases it is a smooth muscle relaxant. So uterine, this thing, patient can go into this thing, or renal failure. So what are the prerequisite? If you are giving magnesium, what all monitoring? What all monitoring?
Final few questions. We are turning, yes. Time is running out, ma'am. Final few questions now.
Yes. Can you just tell me what all you will assess in a patient?
Deep tendon reflex, respiratory rate, and
SpO2.
SpO2 has to be monitored.
So you need to know the normal levels of the magnesium and what are the changes, what all it can lead to with complications with the higher levels, like ECG changes, like increase in PQ interval QRS widening, it can result in. Then it also leads to deep tendon reflexes at what level? Respiratory arrest.
Deep tendon reflexes. Deep tendon reflex is gone at the level of
8 to 10 milligrams. Normal levels are 1.5, 1.7 to 2.4.
1.7 to 2.4
milligrams per deciliter. Then ECG changes occur at 4.8 to 4 to 8. You can see. Then 5 to 10 the ECG changes, and then deep tendon reflexes. Then respiratory arrest and cardiac arrest can also.
Cardiac arrest.
Okay, can you just tell me one thing? There's one more question I would like you to answer. You know the effect. You need to know where all it acts. Magnesium sulfate. So what is where else there can be a role of anesthesiologist when there is a patient of say severe eclampsia or eclampsia?
We can maintain for maintenance of airway patency in these patients patients having seizures.
For patient has reached casualty with hypertensive crisis or patient is convulsing, you can be called. Then if patient has gone into pulmonary edema,
yes, ma'am.
You will be asked. You should know how to manage or treat pulmonary edema. Okay.
Yes, ma'am. Propped up position, oxygen inhalation. In case if patient is having severely depression in respiratory rate or impending towards or respiratory rate is more than 30, then we should ideally ventilate the patient via either non-invasive ventilation.
Very important drug you are forgetting, morphine, which will
cause and nitroglycerin.
Yes, morphine. Then other than this, you can be called for, say, if patient has HELLP syndrome, then also sometimes you'll be required. We did not discuss the platelet count. What is the absolute, at what level you will say that patient cannot be given central neuraxial blockade? So
usually less than 50,000, ma'am. But it says that below 80,000, there is also platelet dysfunction also occurs.
So less than 80,000, you need to be cautious. It is better to go for GA.
Yes, ma'am.
Okay. And what else? Then role in during vaginal delivery, role of epidural, very important.
Yes, ma'am. Epidural should
provide not only pain relief, it will also decrease the catecholamine
level. It increases uteroplacenta flow also.
Yes. Dr. Badani.
Am I audible?
Yes, you are audible.
Hello? Sir, echo aa raha hai. There is an echo with your ear.
Abhi theek hai?
Better. Yes.
And only thing that now about communication, even after delivery, what you will suggest the patient to report? What are the warning signs? And can eclampsia lead after delivery also? Can occur?
Yes, sir. As per ma'am said that it can occur up to 10 days after delivery. So we have to be watchful for the patient. We have to give her supplemental oxygen support. And we have to
what you will tell the patient to report if something happens, and what are the warning signs?
Sir, headache or blurring of vision in patients, if there is occurring this patient, then we would take it as warning sign.
So it's not that cesarean is done and the patient is free of danger. Anything for the next pregnancy? Will you like any prevention can be done for preeclampsia in next delivery? Is it
Sir,
possible?
there's one study that I studied that I had gone through. They recommend that 81 mg of low dose of aspirin
Low-dose
has
aspirin, yes, affects the
from
thromboxane.
12 weeks of pregnancy. Yes. And also there's some role of antioxidants and calcium.
So the role of calcium, there is no longer the role of calcium in this, but low-dose aspirin is still recommended.
This is
Hello.
all.
Can I come in, sir?
Yes.
Dr. Nishant, we are running time out of time.
Yeah,
So I
yeah.
request all the so please finish so we can start the second case immediately.
Yes, yes.
Nishant, you take over. Now this is all from our side.
Yes, thank
very
you.
much.
Thank you so much.
Thank you, madam.
Thank you.
Thank you, sir. So please stay with us. We will start the second case immediately. Nishant, please
Yes,
start.
sir. Yes, sir. Sneha, could you stop sharing, please?
Yes,
And
sir, I'm trying.
there was such a riveting discussion between the examiners and the examinee that I was not wanting to disturb them actually. But yes, we are running short on time. So thank you so much, Dr. Sujata ma'am and Dr. Badani sir, for how to conduct this Viva. You have shown not only to the students but also to some of the young faculty who might be watching how a Viva should be progressing. And before I shift to the next case, Sneha, could you please stop sharing 1 minute?
Yes, sir, I'm trying.
Yes.
Sir.
Yeah.
Yes,
So
sir.
before we go to the next case,
Nishant.
I would.
Sir, can I say something, sir?
Yes. I
Sneha?
would tell you.
Thank you so much, sir, for involving me for this presentation, sir. And I'm really thankful to ma'am. She has been very sweet during the whole presentation. And I'd also like to thank my teachers also, and thank you to you, sir, also and Sharad sir for helping me with the presentation, sir.
Thank you, Sneha. We will talk later. I request Nishant, I will take 30 seconds. Dr. Hari Damodar Singh is the secretary of the Darbhanga city branch, and he is the guide of the Sneha, and he is the HOD also. So I request Dr. Hari Damodar Singh to say a few words. Dr. Hari Damodar Singh, sir. Dr. Hari Damodar Singh, are you? Hello?
Yes. 1 minute, sir. I'll have to allow unmute. Hari Damodar, sir, you can unmute yourself now.
Please unmute yourself.
Yes. And in the meantime, sir, we must give a loud round of applause to Sneha and Sana.
Exactly. Perfect.
Yes. First of all, before anything else, we should give them a loud round of applause because they have had the courage to come up and, despite the fear of failure, they have decided to come and present. So that is very good, Sneha and Sana. Well done to both of you. And you have been very good and very confident, Sneha.
Yes, well done.
Dr. Hari, sir, are you able to unmute yourself?
Good evening.
Good evening, sir. Hari, sir, continue, please.
Sir, good evening.
Good evening, sir.
Nishant, good evening. A nice presentation, and I think she answered almost all the questions asked by madam. We tried our best to have a good presentation.
Absolutely, sir. She has done really well. I'm sure everybody was listened, but she was very confident and very well. She has been very well tutored by the Darbhanga team also, I'm sure.
This has been an encouraging to all the other students who will be participating in coming sessions also.
Yes, sir.
Okay, sir. Start the next session.
Right, sir. So for the next session, the next session is by Dr. Sana, and she'll be discussing about the anesthesia in a patient with prostate hypertrophy. And as the examiners, we have two very eminent experts, and we are very thankful to Dr. Surekha Shinde, madam. So she is a professor of anesthesia at BJ Medical College and Sassoon Hospital of Pune, and she is an MD anesthesiology from BJMC Pune and FACEE in emergency medicine. She has the FIMER fellowship in medical education technology. That is very good medical education. PG diploma in medical legal systems from the Symbiosis University. She has a certificate course in palliative care from TCH Mumbai and more than 20 publications. Yes, more than 20 publications in index, state and national international journals. She won the COPS Award for the best paper in anesthesiology at Nagpur, the National Award for poster presentation at Mysore, and has more than 30 presentations in various state and national conferences. She's a faculty in medical education technology as well as emergency medicine and an examiner of MD, DNB and medical education technology. And our association with my association with the Surekha ma'am also has been quite a lot. We have worked with COVID and she has done tremendous work in COVID. She was the COVID ICU in charge, expert in the Pune Oxygen Committee, nodal officer for oxygen supply and management, member of the ISA National Task Force for COVID, and she has authored a book chapter on COVID management, as well as co-authored the ISA COVID guidelines in the IJA. She was awarded the President Appreciation Award for COVID work at ISA Maharashtra and also won the President Appreciation Award for COVID Task Force work at ISA National. So a very warm welcome, ma'am, and thank you for sparing your valuable time for us.
Thank you, Nishant. Thank you very much for the kind words. I'm looking forward to the association now, and it's a very good gesture from you all to invite me for this. Thank you so much.
Thank you, ma'am. And the other examiner, the next examiner will be very experienced Dr. Shashikant sir. He's done his MD anesthesiology from DMCH, Darbhanga Medical College. He's the ex-head consultant and head of department of anesthesiology at Tata Main Hospital, Jamshedpur. He has been a teacher and guide to many DNB students, and I have been his student also. He was my guide. He was a provider of BLS, ACLS, ATLS, and CTLS, a life active member of the ISA, ISCCM, as well as the IMA, and a past president of the ISA Bihar, Jharkhand state. He is a very good teacher and a very he'll be an asset for the examinees. So a very warm welcome, Shashikant sir. Shashikant sir, are you there?
Sasi sir, आपकी आवाज आ रही है?
Thanks, Nishant and Sarad and ma'am. Good evening.
Thank you so much, sir. Thank you so much.
Let's start.
Yes, Sana, could you please start sharing your slide?
Actually, sir, can I say a word, please?
Yes, please, absolutely.
Firstly, I would like to congratulate Sana because I just came to know, afternoon that she's a second-year student. So, a big round of applause for a second-year student. She has been a role model. At such early age, she's been presenting, so hats off to her. So she can relax and present properly. No tension from examiners. That's what. Let her relax. Thank you so much.
Absolutely. Thank you.
Go
Sana?
ahead. Go ahead,
Yeah.
Sana.
Yes, make it full screen, Sana. Yes. We are not able to hear you, Sana. Could you unmute yourself, please?
Sana, unmute करो.
Can anyone help her?
Huh? Try and unmute yourself.
Sana, hello.
Sarah, there is a taskbar where mute and stop video option is there. You can start your video and unmute yourself. On the down there is a taskbar.
Unmute yourself or try to hear again.
Sana, we are not able to hear you.
Anybody with her? There is a mic option on the left-hand corner downstairs.
Yes, Sana. Okay, now speak. You are unmuted now.
हाँ बेटा
Sana, unmute कर लो.
बड़ी मम्मी से बात करो.
Anand, can you allow her to unmute yourself? Unmute herself.
Is she presented from phone or laptop?
She has a laptop, ma'am. She has a laptop.
Yeah, then that becomes easy actually. Maybe her any fellow colleague help her, you know.
Yes, yes. 1 second. Try now.
Sir, Abhi?
Yes. Yes, Sana. We can hear you.
Okay.
Go ahead. All the best.
Okay. Thank you, ma'am.
Yeah.
Good evening, all.
Good evening, Sana.
Sorry once again. Now, let me begin. 67-year-old Hindu male, resident of Giridih, Jharkhand, and a cook by occupation, belongs to low socioeconomic status, presented with the chief complaints of increased frequency of micturition 2 years and a weak stream of urine 6 months. History of present illness. My patient was apparently symptom-free 2 years back. Then he noted increased frequency of micturition, particularly at night. Earlier, he used to pass urine 4 to 6 times in 24 hours. Now, it has increased to 6 to 8 times during daytimes and 8 to 10 times at night. For the last 6 months, he has also noted weak stream of urine. He has to strain to pass urine, which was further causing thinning of the stream of urine. He has to wait for some time before micturition starts, and even after completion of micturition, he has a sense of incomplete bladder emptying. There is no history of blood in urine, burning micturition, retention of urine, or incontinence. There is no history of pain during micturition or urethral discharge, no history of fever with chills and rigor, no history of trauma to spine or perineum, no history of instrumentation or catheterization, no history of backache or bone pain, no history of loss of weight or appetite, no history of hiccups or drowsiness, no history of unconsciousness or seizure, and no history of cough, chest pain, breathlessness. He is not suffering from any other associated medical diseases like diabetes mellitus, hypertension, bronchial asthma. Past history, there is no history of similar illness in the past and no history of abdominal or perineal surgery in the past. Family history, there is no history of any significant systemic illness in family. He has 2 brothers and 1 sister, all healthy and alive. Personal history, he is married, non-vegetarian in diet, not addicted to alcohol and tobacco in any form. Appetite is good. Sleep pattern is disturbed. Bowel habit is normal. Drug history, no history of drug intake for any illness in the past. and no history of known allergy to any drug. Shall I proceed forward, ma'am, to general examination?
Yeah, please.
On general examination.
One minute, Sana.
Yes,
have you asked the med score of the patient?
Yes, ma'am. Med score was more than 4.
How do you check that?
Ma'am, by asking the patient if he can do his regular routine activities like climbing a few stairs, walking on a level ground, running, doing her or his household chores, or if he can do his heavy strenuous sports activities like playing tennis or soccer. So
how does this help you in deciding your plan of anesthesia?
Ma'am, by med score, we assess the functional capacity of the patient. So if the med score is more than 4, it means it is moderate. Med score is 7 to 10, it is good, and more than 10, it is excellent. So if the med score is less than 4, ma'am, we'll have to be a little bit more careful while inducing anesthesia, ma'am.
Go ahead.
Okay, ma'am. On general examination, patient is sitting comfortably on chair. Patient is conscious, cooperative, and well oriented to time, place, and person. Height is 173 centimeters. Weight is 63 kgs. BMI is 21 kg per meter squares. Facies is normal. Gait is normal. Pallor, icterus, cyanosis absent. Clubbing absent. Edema absent. Lymphadenopathy absent. Pulse 70 beats per minute. Regular in rhythm. Fair in volume. Condition of the arterial wall is normal. No radial and radiofemoral delay. Blood pressure is 120 by 70 mm of Hg taken in the right arm in sitting position. Temperature is 98.1 degree Fahrenheit. Respiration rate is 14 breaths per minute. Abdominal thoracic. Saturation is 98% at room air. Neck veins are not engorged. The spine is normal in alignment and curvature. The spine is
Sana, 1 minute. Why spine examination is important in this case?
Ma'am, spine examination is important, ma'am. First, for our purpose, we have to select the plan of anesthesia. If we are going for regional anesthesia, then we should examine the spine.
That is common to all patients. Why particularly this kind of patient?
Ma'am, also, if our patient, ma'am, if ma'am, a differential diagnosis for this case, we should keep in mind for carcinoma prostate also. So carcinoma prostate patients have metastasis in the spine. So that is why, ma'am, we need to examine the spine.
Any other reason, considering the age of the patient?
Yes, ma'am. Old age patients normally, ma'am, their spine is bent and their ligaments are calcified and ossified. That is why we need to examine spine.
You being the second year student, I'm trying to be more methodical with you. Huh? Okay.
Yes.
Go ahead. Good.
On airway examination, Pug tooths were absent. Inter-incisor gap was 4 centimeter. Length of the upper incisors were 1 centimeter. Mandible protrusion test. The mandibular teeth can be protruded beyond the maxillary teeth. The Malampati score is 2. Palate configuration, there is no arcing and narrowness. Hyromental distance is more than 5 centimeter. Mandibular space compliance is soft palpation. Neck length is more than 8 centimeters. Neck thickness is more than 33 centimeters. And the head and neck movement are within normal range. On systemic examination of the abdomen, on inspection, abdomen is neither distended nor scaphoid. Umbilicus is centrally placed and inverted.
Okay, so now let's stop here. Yes, in all the systemic examination, did you find anything positive? Just to save time, I'm asking.
Ma'am, on systemic examination of the abdomen, ma'am,
all systems, I'm asking you.
Ma'am, positive findings were only in digital rectal examination.
Did you do it yourself or the?
No, ma'am, I took
and these were provided to you?
Ma'am, I asked help from the surgeon colleagues, ma'am.
Okay, fine. Just quickly shift to your slides, then we can come to direct discussion.
The findings of the inspection were confirmed on palpation. So there was no suprapubic fullness, no renal angle fullness. All hernia orifices were intact. External genitalia is normal. On palpation, temperature was not raised, tenderness not present, and no palpable lump. Livers were not enlarged, spleen not palpable, renal angle not tender, hernial orifice intact, external genitalia normal. On percussion, normal tympanic node heard all over the abdomen, no evidence of free fluid in the peritoneal cavity. On auscultation, normal bowel sound heard. The rectal examination, on inspection, perianal skin was normal, no sinuses opening or discharge, no skin tag, sentinel bile or prolapse seen. These findings were confirmed by digital rectal examination. Sensation were all over the perianal. The sensation over the perianal skin is normal. Anal tone is normal. Prostate was enlarged, non-tender, smooth surface, firm in consistency, no induration or nodularity. Median sulcus prominent, and both lateral lobes are enlarged. Rectal mucosa freely mobile over the prostate. Examination of this is cardiovascular system. On inspection, chest is normal in shape, size, and symmetry. Precordium normal in shape. Apical impulse is not appreciated. No engorgement of superficial veins. Carotid pulsations visible. On palpation, apex beat present in the 5th intercostal space in mid-clavicular line. No parasternal heave. No appreciable thrill or pulsation. On auscultation.
Right, Sana. Let's stop it here. Just tell me any positive finding in entire examination, CVS, RS, CNS.
Ma'am, positive findings. Again, the digital rectal examination.
Yeah, that's okay. Nothing positive in any other system. Okay?
No, ma'am, nothing positive.
Have you done CNS examination of this patient?
CNS examination, yes, ma'am.
What were the findings? Just show me. Okay.
If the patient had normal behavior, I had a usual casual chat with the patient and assessed his mental status. And the normal cranial nerve and motor nerve examinations were done. Superficial and deep tendon reflexes were normal.
Why the CNS system is more important in this group of patients?
Ma'am, the patient is of old age, so he can have pre-existing sub-CNS abnormalities also. And we are more concerned about the TURP syndrome that can develop further during the operation, during the TURP procedure. So ma'am, the CNS examination is necessary.
Do you know any tools to understand CNS level perioperatively or preoperatively in checkups?
Not exactly, ma'am.
There are various indices which can be checked preoperatively to exactly mark how the patient's preoperative CNS status is. So the same tool can be used post-operatively, and you can compare and see the changes. Okay, there are a lot many I can share with you. Let's not waste time here. Okay, then now come to the positive diagnosis. Okay.
So a 67-year-old married Hindu male presented with lower urinary tract symptoms for 2 years with enlarged prostate, which is a smooth, non-tender, firm with prominent median sulcus and mobile rectal mucosa. So my provisional diagnosis is bladder outlet obstruction due to benign enlargement of prostate.
What makes you feel it's a benign enlargement of prostate?
Ma'am, the age group, and ma'am, he has symptoms of bladder outlet obstruction, and on DRE findings, the prostate was enlarged, non-tender, and it was firm, ma'am, and the median sulcus was prominent. And ma'am, we also did the prostate-specific antigen test preoperatively, so that also pointed us towards that.
But we have not yet discussed where we have done PSA antigen. Okay.
Yes,
so
ma'am.
From history, how can you confirm whether it's benign or malignant?
Ma'am, from
just a clue. Just a clue.
Ma'am, his symptoms, ma'am.
Yes.
Ma'am, his symptoms that he had 2 years of increased frequency of urine, and his stream of urine, ma'am, weak stream of urine for the last 6 months.
There is no hematuria also.
No hematuria also, yes, ma'am.
Right, Sana. Now, what are your concerns in giving anesthesia for this patient whenever this patient is posted for surgery? What are your major concerns?
Major concerns when this patient, we should prepare the patient well, optimize the patient. He should not have any comorbidities.
Especially this kind of patient I'm asking you. Luckily, your patient does not have any hypertension, diabetic, respiratory problem, kidney problem, right? But had it been something comorbid, then what are your concerns? And even though he's not comorbid, what are your concerns?
This geriatric group patient generally are prone to have hypertension or diabetes or some cardiac issues. So you should optimize them properly, ma'am.
Can you just quickly summarize the changes in various systems in geriatric patient? Just a quick review.
Yes, ma'am. In the CNS, there is a reduced functional CNS tissue. So that decreases the requirement of anesthesia, ma'am. And also they are more prone to hypothermia, ma'am. And in the peripheral nervous system, they have increased sensitivity to neuromuscular blocking agents. So there is prolonged action of neuromuscular blocking agents. I mean, the CVS, their baroreceptor functions are impaired. So they can land into severe hypotension. And
what do you understand by baroreceptor dysfunction?
Ma'am, baroreceptor impaired, ma'am. Reduced ability to compensate, ma'am, for hemorrhage or any vasodilatory changes.
Correct.
And the anesthetic drugs we use are generally cardiopulmonary depressants, suppressants. So we should optimize the patient before surgery. And I mean, their respiratory system, they have reduced alveolar surface area, reduced diffusion capacity. They are prone for pulmonary fibrosis and closing capacities, ma'am, more. Yes, ma'am.
Okay.
They have reduced pulmonary.
FRC is reduced?
Yes, FRC is reduced.
About renal system? Renal system?
Be careful about the airway, ma'am. And their renal functions are also impaired. So the action of the drugs we use can be prolonged.
Okay.
And they're more prone to acute kidney injuries also, higher age group patients, ma'am.
Any changes in geriatric problems in positioning?
Ma'am, in positioning, in this case, ma'am, we have to put the patient in lithotomy position. So ma'am, they are more prone to that nerve damage, ma'am, common peroneal nerve, sciatic nerve, or femoral nerve damage. And they are, ma'am, old age, they have stiff joints, osteoarthritis can also be there. So they can land up into pain or.
So Sana, I think there are a lot many other geriatric issues in these patients. I just wanted to highlight that your case of BP or benign enlargement of prostate may not go towards the anesthesia part, but you can be asked and grilled on the perioperative management and geriatric problems and optimization. So just to sensitize you, I have asked you these questions, okay?
Yes.
So there are a lot many other issues, just for the exam going purpose, this can be the major issue in examination. Okay. So the major problems is geriatric problem and second is surgery related problem. So what kind of surgery this patient will be posted for?
Ma'am, transurethral rectal
Resection.
Yes, ma'am.
Not rectal, resection.
Resection of the prostate. Yes,
prostate. Okay, fine. Now, how will you investigate this patient?
Ma'am, we'll start with basic investigations like CBC.
Tell me the investigation and justify it.
Ma'am, hemoglobin, so that we can calculate the hematocrit value and to calculate the maximum allowable blood loss, total count and differential count to rule out, ma'am, any urinary tract infections.
Yeah.
Or
because sometimes prostatitis can be very common and this patient can lead into septicemia perioperatively. Very good. Yeah.
To know, ma'am, to know the pre-op serum electrolytes is also necessary. Sodium, potassium, calcium, magnesium, renal function test, blood urea, serum creatinine.
Yes.
Ma'am, because generally these patients have elevated serum creatinine, so we need to optimize that. And ma'am, coagulation profile is also necessary, BT, CT, PTINR. And PTINR, ma'am, because mostly geriatric patients have cardiac issues and they are on some antiplatelet drugs, or so ma'am, PTINR is necessary. Ma'am, then elderly patient, that is why ECG and echo.
Now you just said it about antiplatelet drugs. If the patient of yours is on antiplatelets, what precaution you are going to take while anesthetizing?
Ma'am, we should.
This is how we as a student, you know, you put ourselves into maybe a more extended kind of grilling. So if you know the answer, it's better to go in that direction. Okay, now tell me.
Yes, ma'am.
The antiplatelets and the issues during anesthesia.
Ma'am, antiplatelets, and we need to stop some antiplatelets 1 day before or some 5 days before the surgery. So that is why we need to.
Which are those some? Have you read this?
Yes, ma'am. Low dose aspirin we can continue.
Okay.
And clopidogrel we need to stop it 5 days before surgery.
5 to 7 days.
Yeah, 5 to 7 days before surgery.
So now your Viva can go on ASRA guidelines also, right?
Yes, ma'am.
Okay. Continue now the investigation.
Ma'am, blood group and then ECG and echo of the patient.
Okay. Any specific diagnostic? Any specific diagnostic test?
Specific diagnostic test, ma'am. Prostate specific antigen.
Yes. So,
ma'am, to rule out carcinoma prostate, possibility of carcinoma prostate. If the PSA antigen values between 3 to 4, less than 3 to 4 nanogram per ml, then we can rule out carcinoma prostate and be more sure for that is benign enlargement of prostate.
Okay. Now, you have seen the patient.
Yes, ma'am.
You have investigated and the patient is posted 2 days later. So how will you proceed now with your case? How will you optimize? How will you write your preoperative notes and proceed for anesthesia? Let's go one by one.
Ma'am, will obtain a written informed consent from the patient, explain him the whole procedure of anesthesia we'll choose, and also explain him the alternative methods. And ma'am, in brief, we'll also tell him about the surgery, what kind of surgery he'll undergo. And
okay.
One night before, ma'am, we'll put the patient for fasting, ma'am, and 8 hours for solid food and 2 hours for clear liquid.
If your patient is little apprehensive,
yes, ma'am.
Any precaution you will take for apprehensive patient?
Apprehensive patient, yes, ma'am. We advise some anxiolytics to be taken 1 night prior to the surgery. Usually,
any specific anxiolytic you can mention?
Ma'am, alprazolam 0.25 mg 1 night before the surgery.
It's preferably to tell the drug which you are going to use routinely instead of taking haywire. I mean, not beating down the bush. Be very precise with the dose, route, and the agent. Okay?
Yes, ma'am.
Proceed.
Yes, ma'am. So
on the day of surgery.
Okay. On the day of surgery, we'll take the patient in the OT. We'll again explain him the procedure and the anesthesia will give him, and we'll connect the monitors, ma'am, the ECG, NIBP, pulse oximetry.
Okay.
And then we'll start with anesthesia, ma'am.
No, you have explained him the anesthesia part.
Yes,
what anesthesia you have chosen for this patient? I want to ask you now.
Ma'am, for this patient, we choose, ma'am, regional anesthesia, that is subarachnoid block.
Any particular reason why you want to ask about spinal anesthesia for this patient?
Ma'am, why I choose a spinal anesthesia for the patient?
Yeah.
Ma'am, since the patient had no other comorbidities, I thought it would be better to take the patient's spinal anesthesia since the patient would be awake, and I would better communicate with the patient and know his mental status.
Okay. Any other reason why you would go for spinal anesthesia? So in short, what are the merits of spinal anesthesia, especially in an elderly patient going for peripheral surgery?
Ma'am,
Besides patient being awake, are there any merits?
ma'am,
In
usually
general, you can
in
discuss.
general, the geriatric patients have some respiratory problems. So in that case, spinal anesthesia is better than general anesthesia.
Okay. Anything else? I think you can enumerate 10 at least now.
No, ma'am.
Just forget about TURP patients. In general, I'm asking. The merits of regional anesthesia. Now the spectrum of anesthesia is more and more going towards regional anesthesia. So there has to be some advantage or advantages why we choose for regional blocks. So I think you should go back and read it. Okay.
Yes.
Fine. So in TURP patient, what is the surgery which is usually performed? How many TURP patients you have anesthetized so far or witnessed? Maybe in COVID. Maybe in COVID, you may not have that opportunity to witness so many, but at least you have seen.
Yes, ma'am, I've seen, ma'am. I don't remember exactly the numbers, but ma'am,
so there must be plenty, right?
Yes, ma'am.
So what is the procedure? What does surgeon do?
Ma'am, the surgeons, after we give them the patient, after we have given the block, subarachnoid block to the patient, we wait for 5 to 10 minutes. Then we put the patient in lithotomy position. The surgeons then, ma'am, they have a cystoscope. They insert it via the urethral opening. And ma'am, this is inside. Ma'am, they have that tool that they resect and coagulate at the same time using the irrigant fluid. There's an irrigant fluid, continuous irrigation of the bladder is done, and they resect and coagulate.
What kind of cauteries can be used for resection? A lot depends on this. Initially there is to be unipolar cauteries. Now we have switched to bipolar cautery with obvious advantages. Okay. Yes, and one more thing I want to ask you: you have chosen for spinal anesthesia.
Yes, ma'am.
Avoiding general anesthesia, but there are certain demerits of spinal anesthesia, especially in case of TURP. Can you locate the demerit?
Ma'am,
there is one problem in spinal anesthesia, especially in TURP patients.
There is obturator nerve sparing, ma'am, in spinal anesthesia.
Very good.
In GA.
Good.
Okay. Now here comes the question: what is the nerve supply of prostate?
Ma'am, nerve supply, ma'am. Ma'am, prostatic plexus.
Yeah.
From the inferior hypogastric plexus, ma'am. Inferior hypogastric. Yes, ma'am.
What is the root value?
Sympathetic supply is from T11 to L2. Parasympathetic supply is from S2 to S4. Yes, ma'am. Pain fibers are from also from S2 to S4, ma'am.
So, knowing this nerve supply, how can it affect your spinal anesthesia level? Which is the optimum level you can go up to? It can be very comfortable for surgeon.
T10 level, ma'am.
Very fine. So now you have taken the patient inside, you have explained everything. Now about monitoring. What monitors you are going to put for the patient?
10 minutes, ma'am. 10 minutes. Yeah.
ECG, saturated SpO2 and NIBP, ma'am.
Okay. And anything else?
Minimum, ma'am, minimum only these three. And we will monitor urine output.
Yes. How can you monitor urine output during
ma'am.
Now, as Nishan said, there is short of time. I can just explain you the different questions. Like now, I think you must be knowing what are the characteristics of ideal fluids, right?
Yes, ma'am.
Which are the commonly used fluids. Now, just tell me quickly, which is the commonly used fluid for irrigation?
The most commonly used fluid is glycine, 1.5%.
Okay. What are the merits of glycine?
Ma'am, glycine, the advantage, it causes less TURP syndrome, and ma'am, it is electrically inert also. It is non-toxic, transparent, non-hemolytic, and easy to sterilize.
What are the complications glycine can have in patients?
Ma'am, glycine, ma'am, the metabolites of glycine, ammonia and oxalic acid. So hyperammonemia causes, ma'am, nausea and vomiting, and hyperoxaluria leads to renal failure, and hyperglycemia causes, ma'am, transient loss of visual loss, transient visual loss.
Any antidote you know of for this?
Antidote for hyperglycemia?
For glycine toxicity?
Ma'am, prophylactically, we should give arginine.
What is arginine? It is L-arginine. Okay.
L-arginine, yes, ma'am.
What is it? It's a non-essential amino acid. Can you tell me the dose of L-arginine?
4 grams of L-arginine infused over 3 minutes, ma'am.
IV, intravenously.
Yes, ma'am, IV.
Okay. Now, coming to your most awaited complication. So, what are the common complications with TURP surgery?
Common complications include hemorrhage, TURP syndrome, sepsis, DIC, bladder perforation.
Okay. How will you come to know that patient has undergone bladder perforation?
Ma'am, the patient will complain of, ma'am, firstly, the irrigant fluid will not come with that speed at it was coming before, and the patient's the blood pressure will rise and then fall after some time, and patient will complain of sharp pain in the upper abdomen, over the shoulders, and nausea, vomiting also, ma'am.
Now, the TURP syndrome has to be discussed because that is the crux of any BEP case. So now tell me, what is TURP syndrome? What are the signs and symptoms? And then we can discuss later.
Ma'am, TURP syndrome is a neurological manifestation due to acute hypoosmolarity. The risk factors can be open prostatic sinuses, or the high irrigation pressure, lengthy procedure, or hypotonic irrigants used. Ma'am, they lead to hypervolemia, and it can lead to increased capillary leak. And when we give that spinal anesthesia, ma'am, there is cardiovascular collapse. And TURP syndrome is characterized by delusional hyponatremia also, ma'am.
Which is the triad of TURP syndrome?
Ma'am, triad of syndrome is hypertension, bradycardia, and altered mental status.
Any factors which can prevent TURP syndrome? Prophylactically, you can engage patient into? What are those factors? And you can take prophylactic steps to avoid occurrence of TURP syndrome.
Yes, ma'am. So, ma'am, the patient should be prepared properly for surgery. That includes adequate hydration, electrolyte analysis, and coagulation profile should be checked beforehand. We should limit the surgery within 60 minutes.
Correct.
The bag of the irrigation fluid, ma'am, it should not be placed at a height more than 60 centimeters. And ma'am, the surgeon should limit the extent of the bladder distension also. Or frequent drainage of the bladder should take place.
How will you suspect that patient is going towards TURP syndrome?
Ma'am, firstly, if the patient gets restless, or if he is not comfortable, he becomes restless, and his BP is rising, and he's having bradycardia, will ask for his vision also. If there's some blurring of vision or halos, so we could suspect that patient is landing into TURP syndrome.
Are there any levels of TURP syndrome depending upon any levels of CBP or electrolytes?
Yes, ma'am. Sodium, ma'am, serum sodium levels we see. If the serum sodium level is up to 120, so there are signs of serious depression. On ECG, we can say QRS widening.
Correct.
And ma'am, patient is not that much symptomatic then, only there's some confusion and restlessness. And when the serum sodium level is less than 115 milligrams per liter, then the patient develops nausea, somnolence, and he may undergo bradycardia, widening of the QRS complexes, ST elevation. And when the level further drops to less than 110, then the patient undergoes ventricular fibrillation and can develop respiratory and cardiac arrest. And seizures and coma is also there.
Suppose if you diagnose this patient in an early stage, how will you proceed for the treatment?
For the treatment, we'll maintain oxygenation and circulatory support of the patient. We'll notify the surgeon and ask him to maintain homeostasis and then stop the procedure or terminate the procedure. And then immediately we'll send for ABG and serum electrolytes. And ma'am, then if the symptoms are mild, then only fluid restriction and diuretic, loop diuretic like furosemide, ma'am, this will help.
Which other diuretic can be used in this patient?
Mannitol can be used.
So which is better? How will you compare mannitol versus classics or furosemide?
Furosemide is better, but because ma'am furosemide causes ma'am sodium loss उसमें ज़्यादा होता है.
Okay. So which is better?
Furosemide, ma'am.
Initial stages, furosemide is better.
Yes, ma'am.
What is the next step in treatment?
Ma'am, for bradycardia, we'll advise glycopyrroles, and for now, if the patient has severe symptoms, उसके लिए बताएं, ma'am.
Yeah, please.
If the patient has severe symptoms, so that is when the serum sodium level is less than 115, then we'll go for hypertonic saline, 3% hypertonic saline. Okay. We should use it.
What is the rate? What is the rate?
Less than 100 ml per hour.
Okay. Why you need to be less than 100 milligram per hour?
Ma'am, we do not want to do rapid correction of sodium, serum sodium, because it leads to central pontine myelinolysis, which is an irreversible change, ma'am.
Suppose you are caught unaware and there is no hypertonic saline in your OT. Is there any other management protocol?
8.4% of NHCO3.
Okay, good. Fine. How will you monitor this patient now who's gone into TRP syndrome?
Ma'am, we'll obtain a 12-lead ECG and we'll routinely monitor his serum electrolytes.
Okay.
Ma'am,
anything else?
Ma'am, and check his mental status till his symptoms resolve.
No, now just let me ask you a question. Now this patient is well treated without any TRP problems, shifted to your surgical ICU, and you are monitoring in surgical ICU. And what is done in post-operative period by the surgeons for this patient? Any idea?
Yes, ma'am. They keep bladder irrigation for 24 hours. That time the irrigation fluid is normal saline.
Okay. Well, what do you really check with this bladder irrigation? What do you check? You are a resident on call there and you are monitoring the patient. What are the signs and symptoms which can...
And we'll check for hypothermia.
Yeah, hypothermia. Anything else?
And blood loss.
Okay. If the irrigating fluid, it should go in a clear zone over the period of 8 to 9 hours. Suppose the clarity is not clear and the color of the irrigating fluid is becoming darker and darker. What is your differential diagnosis?
In that
it's
case,
a very common scenario.
Yes, ma'am. The patient can have DIC, ma'am. Disseminated intravascular coagulation or septicemia.
So how will you check now? How will you proceed for the management?
Ma'am, we'll obtain his CBC report once again. We'll check for hemoglobin levels and then we'll advise FFP, fresh frozen plasma or cryoprecipitates. And check for his blood pressure routinely.
Final few questions, ma'am.
Surgery also might have to interfere with hemostasis also. One more thing you said about hypothermia. Are there any perioperative measures which can prevent this complication? About hypothermia?
They should, the irrigant fluid should be warm, and the fluid which we are using for, we should also warm that fluid. The OT temperature should be optimized.
And what is the reason for post-operative this bleeding in this TRP patient? Besides sepsis, what kind of DIC it is?
Reason for, ma'am,
any specific reason?
might not have been secured, ma'am, by the surgeon.
Any specific reason?
The venous, the prostatic sinuses might be kept open, ma'am. Open right
could be, the reason could be consumptive coagulopathy also. It could be dilational thrombocytopenia. That is a commonest thing.
Yes, ma'am.
So what is the post-operative care for the pain relief in this patient?
Ma'am, we can use opioids also, ma'am, IV opioids or paracetamol infusion.
What makes you use opioids in this patient? If I'm the anesthesiologist, I wouldn't be using opioids. What is the occurrence of TRP syndrome? For how long it can occur?
TRP syndrome occurs within 15 minutes of the surgery till 24 hours after the surgery.
So is your opioid a good option?
No, ma'am.
Why?
Ma'am, it also, opioids causes, ma'am, depression of the respiratory depression. And they also sedate the patient. So we might not know their mental status then up till 24 hours. So we should avoid, ma'am.
So NSAID is a better option, especially for first 24 hours.
First 24 hours. Yes, ma'am.
Good. See, this is how you can think about physiology, anatomy, and you can automatically go for your anesthesia protocol. Nothing has to be by-hearted. Your Viva can go anywhere depending upon your specific response rate.
Yes.
So I think, Sana, we can sum up. So the crux of this case, just for each and every exam going student who's here, Sana has answered very well, I think, for her second year criteria. So any TRP patient, the crux of discussion would be prostate itself and geriatric problems. Next will be anatomy and nerve supply and venous supply of prostate. Then could be the procedure itself. Then about ideal irrigating fluids, various fluids, saline, glycine, mannitol, all sorts of the advantages, disadvantages, all, and what is the ideal choice. Then about the procedure itself, about occurrence of TRP syndrome, what are the pre-monitoring symptoms, what are the different stages of TRP syndrome, and treating accordingly. Then hyponatremia, the classic triad, and different ECG and cardiovascular problems and central nervous system manifestation. Then about treatment, how to go about it. It should be slow and steady because the very fast treatment of sodium can have central myelinosis, so that has to be avoided. Then amount of maximum allowable blood loss has to be taken up amount. Then monitoring other complications, because TRP is not the only complication which can be addressed in prostate surgery, even bladder perforation, septicemia. The septicemia can be more dangerous if not treated properly. It can cause generalized serious collapse and death also eventually. Post-operative care is very, very important. Now, just to avoid all these complications, are there any surgical interventions which can be modified to avoid this TRP syndrome? Sana?
Yes, ma'am. LTURP, they use...
what is that?
Ma'am, light source is used for resection and coagulation of the...
It's a laser kind of surgery.
Yes, ma'am, laser kind of surgery. Helium laser is used, ma'am.
What are the other advantages of this LTRP? Especially with the choice of fluid. Which fluid can be used in LTRP?
Ma'am, normal saline.
Yeah. So in other way, our routine TRP, we are using glycine. to avoid all other complications. But with LSR, we can use normal physiological saline. So all these complications of sodium loss and everything can be avoided. And there is very minimum chances of hyponatremia. Okay?
Yes, ma'am. Yes, ma'am.
Sir, anything else we want to address to?
Shashikant sir?
Shashikant sir?
Yes, good evening.
Yes.
In serious cases, you may develop BTVF and patient
Yes,
may admit
yes.
on table. So, first of all, during OT preparation, the anesthesiologist must be aware of where is the defibrillator, whether it is checked properly or not, because we have encountered surgeon is operating, not listening to anesthesiologist. Okay, bleeding is not controlled. Patient went into TURP syndrome, cardiac arrest. One patient revived because of the all activity what we discussed, like giving sodium ABCD approach, including defibrillation and 3% normal, 3% saline. Other patient we could not save because it was too late. Whatever discussed today, it all happens on table. And most of the time, anesthesiologists either they do not check their defibrillator, they do not know how to use the defibrillator. So, Dr. Sana, can you say what are the things which one should be checking in the defibrillator as a PGA student? Hello.
Yes,
Yes,
sir.
Sana.
Dr. Sana, how you will check the defibrillator? Hello.
Yes, sir.
How will you check the defibrillator? Have you got a defibrillator in your OT
Yes,
somewhere?
sir. Yes, sir.
Which company?
Very practical question, sir. Very practical.
Which company? Philips or something else? Whatever. Have you seen the defibrillator?
Yes, sir.
What are the parts of defibrillator?
Parts I cannot explain, sir.
There must be some power source. There must be some power source. Then there must be some pedal.
Yes, sir.
There must be some screen.
Yes, sir.
Okay. So you must be seeing them. Have you touched this defibrillator?
Yes, sir.
Have you opened up the pedal?
Yes, sir.
Okay. Then what do you do? Is your teacher teaching this defibrillator?
Yes, sir. They've taught us.
Okay. So what? but see, you go. It will be full question during the equipment examination, and one of my PG failed once because they could not demonstrate the defibrillator properly. What is difference between bipolar, unipolar? Do you know there are bipolar, unipolar defibrillators? No. So you should go and learn how to check the defibrillator and how to defibrillate the patient. What is difference between defibrillation and the cardioversion?
Cardioversion, yes, sir.
And what is the this ACLS means use of adrenaline, CPR, defibrillator in cases of BTVF.
Yes.
Okay, Dr. Sana.
Yes, sir.
As a second year student, you have presented rightly.
Very nice. And
only thing, yes, ma'am.
One more thing I want to address here. While patient is being given spinal anesthesia and surgery starts, many times patient gets restless because it's an old patient with lot many comorbidities, and patient is given lithotomy, and patient goes haywire, and his mental status is not good, and patient gets irritated. And the first and foremost reaction of the patient anesthesiologist little immature is to give sedation. So this practice has to be condemned. Actually, patient should be counseled. Patient should be counseled.
Because most of the time, either patient is apprehensive or he is going into shock, a spinal shock.
Yeah.
Because of the high block. Why, Dr. Sana, why this patient can go into high level of block? Elderly, 67 years old lady, patient with
the spaces in the subarachnoid spaces in old patients are narrower because their ligaments are calcified. So
any other patient?
Any other reason? Any other reason?
Any other reason? Yes.
So their baroreceptor the baroreceptors are impaired, so their compensatory mechanism
to avoid time loss. Is there any changes in the cardiovascular system in the elderly persons? Like in the vessels, they are thick vessels. There is the constricted blood volumes. When there is sudden vasodilatation of a spinal, probably there is hypotension. If they are not co-loaded or and taken care of with the vasopressors.
Yes.
So sudden redistribution of the blood in the system, that is called redistributive shock or a spinal shock,
Yes.
which is common in elderly. So you should remember the cardiovascular changes, and why you said that these patients should be going for echo regularly. What you will get from this echo in this elderly patient?
Mainly the ejection fraction, sir.
Anything else specific? Because the
Very specific.
asymptomatic. There is no blood pressure, high blood pressure, but still there is changes in the cardiovascular system. What is their left ventricular condition?
Sir,
what are the changes in the left ventricle?
Hypertrophy of the left.
Concentric hypertrophy, rightly. Why?
Yes.
Why? Probable pathology?
Congestive cardiac failure, sir.
No. The patient is normal. You said that his METs is 3 or 4.
Yes, sir.
It is because of changes in the vessels. So
Yes.
their afterload may be to compensate the afterload, the ventricle is getting hypertrophy.
Yes.
And it is compensated. Patient is not symptomatic. Blood pressure has not increased. And that also creates sometimes the diastolic dysfunction, which is very difficult to judge clinically.
Yes.
Okay?
Yes.
So if you are doing echo, resting echo, systolic function, diastolic function, ejection fraction, everything may be normal.
Yes.
Only thing, if you will see the Doppler through the mitral area, and if you will see that the atrial kick speed through the atrium to the ventricle is less, this indicates that patient is having some problem of the atrium along with the ventricle. So that information you can only get. Otherwise, resting echo has got no much of the meaning. Yes, ECG has got. Chest X-ray, you can predict if there is some COPD changes, other things. Okay.
Yes, sir.
So cardiovascular changes occurs in the heart, in the vessels, in the autonomic supply of the heart, baroreceptor, other things. Even endothelium of the blood vessels are affected. That's why when you do the arterial examination during pulse, you see whether the arteries are thickened or not.
Thickened or not, yes.
That's all from my side. Thank you, ma'am.
Yeah, one more thing. If your patients after 24 hours is showing mental changes, so would you attribute it to the post-operative cognitive dysfunction?
Yes. Nowadays, post-operative cognitive disorders are a real problem, and there are Monterey scales, all those things.
After 24 hours, it would not be post-operative cognitive disorder, because generally it starts from 7th day of the surgery.
No, you are right. Dr. Sana, you are saying it weeks. POCD is coming within a week during first week. But patient of acute delirium, which is immediate post-op or in 24 hours, 48 hours, can progress into post-operative cognitive disorder. Okay.
Yes, sir.
So how will you manage this?
How will you manage that? Yeah.
This patient is delirium because of hyponatremia, because of the TURP syndrome, or because of the cognitive disorder.
Function.
So on the basis of pre-op history, and we'll do routine serum electrolytes examination and routine ABG.
You have got ABG in your hand. You will find out whether sodium, potassium electrolyte.
Sodium, ABG, yes.
Yes.
Osmolality is okay or not. You will also find whether hypoxemia is there or not, PaO2.
Yes.
And everything patient was pre-op okay. But the cognition, what is cognition? What is cognitive disorder?
Intelligence. So intelligence of the patient.
Not intelligence. There are different tools for intelligence. Okay, there are different tools for cognition.
So what is the function of the brain? Sorry, baseline I'm trying to say.
Yeah, good.
You are a student second year. What is the function of the brain?
Function of the brain.
Of course. Function. It receives information.
Receives information and
it codes it, analysis, receiving of information, analysis of the information, then coding and then decoding, means memorizing it and then retrieving from the memory. And then coordination between sensory, motor and other system for work. Okay.
Yes.
So in this function, if there is mildest, slightest change, that is, you can say behavior change or function change, that can be found out by the different tools. Any person after 60, depending upon the function and other things, it has been seen that after 65, most of the people have got some form of cognition problem, which get aggravated even after spinal anesthesia, hip surgery in elderly, and India elderly population is increasing. So those scale must be known. Okay.
Nowadays, even bedside mini mental test is also available. You can just do within minutes.
Yes.
Mini mental test. And always this post-operative delirium is a diagnosis by exclusion. We have to first rule out all the dangerous, life-threatening complications first, and then you can label it as post-operative delirium, as POCD. What is a pharmacological measure? How can you treat it once everything else is ruled out?
Dr. Sana.
Dr. Sana?
So for POCD, ma'am.
No, delirium. Patient is in delirium. And sodium is okay. Oxygen saturation is okay.
Everything is all right.
There is no acidosis. Urine output is adequate. But he is abusive, he is aggressive, or he is depressed. He is aggressive, suppose. उसको सब कोई बांध रहा है, CCU में ले गए हो. Okay?
Yes.
So what you will do with that patient?
So ventilation, airway and circulation से secure करना है.
Airway is okay.
Yes, everything is all right.
Everything is all right. He is even showing tongue. He is abusive. He is shouting. He is jumping on the bed.
Sedation, sir.
What sedation?
So, midazolam, benzodiazepines.
Okay, you have given midazolam and taking care of airway also, oxygenating. Then it not responds. Midazolam after 5 minutes again he has started doing the same thing. Haloperidol you can give.
Haloperidol can be used.
Haloperidol.
Yeah.
Only thing you have to be careful again, over sedation versus this delirious state.
To be given low dose titrated doses, haloperidol works better in this age.
Yes, ma'am. So these are real clinical problems. And by the way, what do you mean by osmolarity? How you calculate the plasma osmolarity, Dr. Sana?
Sir, I think this should be the last question, sir. She's already been there for 1 hour. So we'll have to, yeah, she's done.
She's answering also well, considering her second year knowledge.
Yeah.
So many questions means, you know,
yes, sir. I mean, this is the TURP is Samundar. Ma'am was saying it will be geriatric also and TURP also. And yes.
I mean, you never know how your viva can be anywhere. Yes. It can be a theory question also.
What is sodium level in the plasma, Nasana?
So 135 to 145 milliequivalents.
Suppose 145 is the sodium, 140. So what will be the plasma osmolarity? 2 into
sodium. 2 into sodium.
What is the formula? 2 into sodium. Potassium को इससे नहीं मानते हैं क्योंकि उसका potassium extra cellular बहुत कम. Is it? So 2 into sodium.
2 into sodium.
Plus glucose by, you must remember it in external exam. You may be asked anywhere.
Yes, sir.
Glucose by 18.
18.
Urine by 2.8 or 4 or 3.
Yes.
Why this formula I have asked you? because in cases of hyperglycemia, if these patients are diabetic and hyperglycemia, osmolality will be high. In cases of vaccine toxicity, osmolality will be maintained. Whereas in cases of dilutional hyponatremia, osmolarity will be less. Means hypervolumic, no, itna glycine there. Okay, so this formula must be remembered.
Yes.
This is last question from my side.
And
Thank you, ma'am.
One more thing also, I think if this patient luckily is not having any comorbidity, but if the patient is having comorbidity and having some medication, so which medications should be stopped, which should be continued, which should be relieved, which are the anticoagulants, the breathing therapy, all this can be also asked in your exam.
Breathing therapy, everything is there.
Thank you. I think.
Okay, so thank
Sorry,
you.
We took time. Okay, thank you.
No, sir. Sorry, and first of all,
if it's a routine case, we can take it for 2 hours, 3 hours also in our hospital. Yeah.
And very it was an engaging viva again, and Dr. Surekha madam was just leading all the way and showing us also how the viva should progress. Thank you so much, Surekha ma'am. Your presence has added so much of quality.
Good job. Yeah.
Yes, both of them have done a great job, and just because they have agreed.
Sneha.
Yes, ma'am. Simply by agreeing to present, they have won more than half the battle.
Correct.
And they will realize that after some time, when they are giving the exams, that these cases they'll probably not even need to prepare again, because they've been working so hard for the last 4 or 5 days.
Yeah.
So thank you, Sana, and thank you, Sneha. I think we are running short on time. So do we have Dinesh sir? I think he must have left because it is quite some time. Dinesh sir, are you there? So what I'll do, ma'am, is I'll just start the Thanksgiving and felicitation. And to begin with, first of all, both you and Sujata ma'am and Shashikant sir and Badani sir have been such a nice examiners.
Thank you so much, sir.
Thank you, Nishant.
Thank you, Nishant.
Yes, ma'am. So first of all, ma'am, I'll ask you to wait for a little bit and just hand over some certificates of appreciation to both Sana and Sneha. So first of all, Sneha, are you there?
She was there just now.
Yes, sir. I'm still there.
Yeah, you've done very well. And ma'am, could you just, because this certificate will be sent to her also, and you can just hand over the certificate of appreciation to Sneha.
Yeah.
So Sana, she has to tell.
Sana, very happily and proudly, I'm handing over this certificate of appreciation to you. Congratulations. You have done a good job.
Dr. Mukta.
Ma'am.
Sneha.
Oh, yes, ma'am. Thank you, ma'am.
Yeah.
Right. So, Sneha, do you want to say anything?
No. Thank you, sir. Thank you so much for your support, sir, and your guidance, sir. That was really helpful, sir.
She was fantastic for her exam going, actually.
Yes. Very nice, Sneha. Very nice. We are all proud of you.
Thank you, sir.
Next, Sana Fatima. She's from RIMS in Ranchi. And again, Surekha ma'am, could you please do the honors?
Yes. Dr. Sana, you're there? Yeah.
Yes, ma'am.
Very happily, I give you the certificate of appreciation.
Thank you so much.
For your presenting case discussion on TRP. Well done. Pick it up.
Thank you, ma'am.
Stay in touch.
Well done, Sana.
Yes, ma'am.
Very good, Sana.
Thank you, sir.
Badani sir, you there, sir? Badani sir.
He's there, actually. He's muted. He's muted.
Badani sir, could you please unmute yourself? Because I'll request him to present this certificates to both you and Sujata ma'am.
Okay.
So he's the current dean of AIMS Patna ma'am, and head of department also. Badani sir, are you there, sir? I just heard him. Shashikant sir. Shashikant sir, can you present the award to certificate of appreciation to Sujata ma'am? Sujata ma'am, if is she there? She had to go for a party and despite the fact that she had an engagement, she was kind enough to spare her valuable time. This she had mentioned last week itself. So I think Sujata ma'am probably might be there. Are you there, Sujata ma'am? Shashikant sir, could you please hand over this certificate to Sujata ma'am in absentia?
Yes, she's not there, but she rightly started the these examination and PG, guiding them how to approach the question and answer. And well done, madam. And we also learned from both of the madam, Dr. Sujata as well as Dr. Surekha, the way the examination was conducted. Thank you, Dr. Sujata. Handing over the certificate to you, ma'am.
So, Dr. Badani sir, also, sir, you can hand over. Badani sir probably is muted. Sir, could you, for Dr. Shashikant, if you could hand over the certificate to him, then he'll hand over it back to you. Surekha ma'am.
Okay, and Dr. Shashika, I very happily hand over this certificate of appreciation to you, being my co-examiner. Thank you so much, Shashikant sir.
Thank you. I learned a lot from you. Thank you.
Sir. We are all growing together, sir. Nishant can vouch on that, how we grew together in COVID. We learned so much from each other and we have become a family now.
Yes, ma'am, absolutely. And sir, ma'am, this there is a spelling error. I apologize for that. It will be corrected when the certificate is sent to you.
Sir. This is
and
SHIND.
Yes, yes, I know that, ma'am. I saw it late actually.
It's okay.
And we'll correct it. Shashikant sir, could you please hand over the certificate to ma'am, please?
This is my respect to you, and please accept the certificate. And really, I learned from you.
Thank you so much, sir. My pleasure. I'm humbled.
How to motivate the young coming anesthesiologists.
I'm humbled, sir.
So, thank you. Badani sir is here.
Yes. I got some phone call because there was a fire in the girls' hostel. So Dr. Mukta informed me a girl was cooking something. So I had to attend that call.
So, okay. Sir, in your absence, we have handed over some certificates.
No. Thank you very much for all the Nishant, Sharad, DK Singh, and all, but especially both the students, they were marvelous.
Yes.
And it was, and hopefully other students who were present will learn. And it's a not very good thing that the examiners were nice. Examiners should look dangerous and.
Sir, we didn't want to put their moral down, sir. Next time,
no, it's not for moral. It's just in a lighter note because this is an idea that if you go through bad times, then in the real time you enjoy when it is less bad. That is the basic idea of all these things. So, but anyway, it's just in lighter note.
It is said that if you bleed in this, you can enjoy at war, like
real exam. Yes, that is the basic. But yes, they were very good prepared, and most of the questions they could answer. That is the and both of you from the external side and internal. Me and Shashi both are MBBS batchmates, so that's nice to be here in the team. Thank you very much for being in the things. Thank you, Nishant and Sharad.
Really. Okay. Thank you, Nishant and Sharad. It was a very wonderful association, and I will feel very humbled and privileged to be part of this wonderful ISA program. I expect many more such associations in future. Actually, I really enjoyed it.
Absolutely, ma'am. You are part of the family, and whenever we have a chance, Badani sir. Yes. We will be more than happy to have you back, ma'am. It was an honor. So with that, I think we can come to the end. If there is anyone who wants to speak anything or any comments, they are welcome. I think this meeting is otherwise officially over. So we can just stop the recording. And if there is anyone who wishes to add any comment or any suggestions, ma'am, how can we improve? What else can we do for these postgraduates? If there is any suggestion from your side, we'll be happy to know.
Okay. See, today it was like a mock testing, but we went very methodically, like not to miss out anything. But it cannot be the same in real scenario when actually exam. Just examiner can just grill you on a very single, like sir was talking about osmolality. So entire viva for half an hour can go on entirely on osmolality. Huh? Everything can go on post-operatively cognitive dysfunction. So students should not take it for granted that it's a QRP case. मुझे तो सब आता है कि hyponatremia, this and that. So nothing should be taken for granted. It has to be holistic approach while you study. Each and every loophole should be addressed.
Yes.
I mean, that is the take-home message. Otherwise, they just stuck on the clinical pre-anesthesia checkup also.
Yes. What I liked about today's session was, ma'am, that the preparation that the examiner, like you had come with a full preparation with the questions that need to be asked. That is how we also need to practice taking vivas, in which there must be must know areas, there must be should know areas, and nice to know areas. The way you had all the questions prepared, that the must know areas must be covered by all students, the should know areas can be covered, and if the student is doing well, then we can go to the nice to know areas. And that is how vivas actually should be taken by us also. We also need to structure our vivas and prepare for the viva before taking it, just as the student is preparing for the giving the viva.
So nowadays in medical education, assessment is more important, how you assess, it should be more objective than subjective. And one more thing, while I'm taking exams in DNB and MD, my first address is how safe is the anesthesiologist. Now, how smart he is. Sometimes students know all kind of recent advances, this, the good English, everything, but that is not a very important criteria according to me to pass. How he is safe, how patient can be safely handed over to him in a society when he takes this exit level. That is the criteria for, according to me, to pass him in examination.
Absolutely. So you've done your FIMER for medical education also.
Yes,
Yes. Do you go in for these color-coded viva sets or nothing? No?
No, sir, not yet.
Not yet. Okay. But that is one thing that we can incorporate, that the structured viva with color-coded cards. That is normally done in the West. And regarding these postgraduate sessions, what else can be done? What is it that you do in Maharashtra, ma'am?
In what sense, sir?
For postgraduate webinars and all?
Yeah, we have webinars, we have case presentations, we have tutorials also, we have journal club also. But in COVID, I think journal club and all, etc., was little taken on a back seat. But case presentations we do very religiously, sir. All short cases, long cases, and we do it for actually 2 to 3 hours. A single case can go up to 3 hours. Sometimes we don't even finish. The part 2 can be taken, that anesthesia management taken some other day. So each and every aspect is discussed, not to keep anything for option.
Right. So if there is anybody who wants to say anything, Vinita ma'am is here, Rajiv sir is here, Dr. Shalendra, Dr. Avinash, or if there is nothing else to say, we can just wind it up.
I think we should have exchange of ideas, inter-state also, isn't it?
Yes, ma'am. Yes, ma'am. So now, with profound gratitude, ma'am, the ISA, on behalf of all the office bearers of ISA Bihar Jharkhand, I would like to thank you profusely for sparing your time.
Thank you so much, sir. Thank you so much. My pleasure.
Thank you so much, ma'am. Thank you, everyone. Good night, everyone.
Good night. Bye. Thanks a lot.